Okay, let's get to it. So again, thank you so much everybody for joining us today. We are pleased to welcome Dr. Carla Torrent, who is a neuroscientist, tenured researcher. She has worked at the Hospital Clínic de Barcelona since 2001, and she is also a collaborating researcher at CIBERSAM in the Bipolar and Depressive unit. She's authored over 150 publications exploring cognition, treatment adherence, and psychological interventions in bipolar disorder. She has also helped to develop the first cognitive training-based rehabilitation programs to improve psychological functioning, and she also now leads projects focused on prevention, resilience, and cognitive reserve. So again, thank you so much, Dr. Torrent, for spending some time with us today. Really excited to have you. And again, thank you everyone for joining. I will go ahead and send it over to you. Let's see what you have to say.
Mhm. Hello. Hello, everyone. Thank you very much for the opportunity being here today in this webinar that I hope is interest of you. I'm going to talk about a topic which has been my research focus for many years, my research area of interest. And I organized this webinar through 7 questions so that I, I will ask these questions and we will try to answer through as we go along these questions. So first of all, as a before starting with the main topic, I just want to share some. I don't know. Doesn't go further. Mm, sorry, a moment. Ah, yes, now was sorry. Okay. So I want to share some of a brief introduction with some short notes about bipolar disorder that everybody that we know, but just as a context. So bipolar disorder is a mental condition characterized by extreme mood swings that include emotional highs like mania or hypomania, and lows that is depressions. So in the many, this is affecting a prevalence between 2 and 6% of people. If we take into account bipolar spectrum, this means that we include as well the mild forms of the condition. So when we talk about depression, we talk about episodes of sadness, of hopelessness, low energy, loss of interest, and difficulty in concentrating or making decisions. And when we talk about mania, we talk about episodes of abnormally elevated or irritable mood and increased energy, decreased need for sleep, rapid speech, impulsive behavior, sometimes as well not always, but often they come as well psychotic symptoms, and requires sometimes as well hospitalization. Hypomania, it's similar the symptoms as mania, but doesn't have so much impact in the daily life, but it can be noticed by the others. As when we talk about causes and triggers, when we talk about causes of this bipolar disorder, is a mix of genetic and biological factors, and then triggering normally are related to environmental factors such as stress, life events that they cause stress to the person. Uh, it's a chronic and recurrent condition. There are different types of bipolar disorder as well. We can talk about bipolar 1, bipolar 2, cyclothymia. I don't know, I have problems to, yet. Cyclothymia, and then we talk about bipolar 1 when it involves at least one full manic episode, and of course, sometimes as well depressive episodes after the mania. Bipolar 2, when we talk about involves hypomanic and depressive episodes, but not full manic episodes. And cyclothymia, it's more a chronic condition, fluctuating mood changes with milder hypomanic and depressive symptoms for at least 2 years. And fortunately, we have treatment as well for this condition. We can treat with psychological, with pharmacological treatments. Normally, we use mood stabilizer, antipsychotics, sometimes antidepressants when it's needed, and as well we have many psychosocial interventions, psychotherapy that can help as well as adjunctive treatment. And then it's very important, all this lifestyle management, sleep regulation, and social support are also essential then after during the webinar, we'll talk about this as well. So I just asked the first question. The first question is we are going to talk about cognition during this webinar. So what does this mean? What is cognition meaning? So cognition includes all the processes that they take place in the brain and relates to acts of thinking, deciding, planning, remembering, and paying attention. And the question is why we could think that bipolar disorder can have some cognitive dysfunctions as well. And this is why, because all these processes that related to cognition, all these thought processes happening in the brain, it's also affecting certain areas of brain relating to these cognitive processes, and this all this mood regulation and all these psychiatric symptoms are as well. They share some of these brain regions. This is why especially, for example, when we are talking about the limbic system, for example, with the amygdala, which is related to, it's in charge to proceed all the emotions. When it's this amygdala overload, sometimes we can not take or make the right decisions. Hippocampus, for example, it's related to all these memory processes, how we encode information, how we can retrieve this information back. And then, for example, prefrontal cortex is as well affected. And prefrontal cortex, as we're going to talk this a bit later on, it's related to executive functions, which are one of the cognitive domains affected as well in patients with bipolar disorder. I'm sharing this. This is a review published many years ago now, but it's still very updated and it's very well written and very interesting to go through it. Because they talk about, we are talking today, we are going to talk about bipolar disorder, but what happens as well with other psychiatric diagnoses, diseases. So cognitive dysfunctions are not specific for bipolar disorder. They are happening for the same reason we were talking before, because of the brain, as the brain regions are affected in the psychiatric diagnosis. So it's as well, cognition is affected in schizophrenia, in autism spectrum disorder, ADHD, obsessive compulsive disorder, in PTSD, post-traumatic stress disorder, panic disorder, in unipolar depression as well, without hypomanias and manias, that it's just affective, belonging to the affective disorder. So we can find different domains are as well affected. So it's not something which is specific from bipolar disorder. And sometimes I'm going to discuss only the differences with schizophrenia, but sometimes the main domains are affected. It's only the qualitatively are affected the same domain sometimes, but just quantitatively are different, or some of the domains are more affected in one disorder than the other. But it's important to say that cognitive dysfunction is not so much controlled and is highly relevant dimension in psychiatric disorders, that they go sometimes beyond as well the traditional diagnostic boundaries. The second question for today is that what is the cognitive profile in bipolar disorder? So what will be the picture of cognitive dysfunction? So first of all, I'm going to talk about the prevalence. So how many people are with bipolar disorder are affected with cognitive dysfunctions? Between 40 and 60. This means that not everybody with this diagnosis, with bipolar diagnosis, they have cognitive problems. For example, if we talk about with schizophrenia, the prevalence rises up between 70 and 90%. So it's a bit lower for bipolar patients. One important thing is to say that this cognitive impairment is as well during remission, not only during acute phases, not only during manic or depressive episodes, that of course we have these cognitive dysfunctions, but as well during remission. This was something that before, as many years ago, when the research in cognition was more pointed out in schizophrenia, the researchers, they thought that that in bipolar patients, once they recover the episode, they recover again all the cognitive functions. But with the time, they realized that this was not like this, and this is why, with a little delay regarding schizophrenia, we started as well in bipolar disorder just investigating these aspects. For example, in our team in 2005, I think we published one of the first papers, one of the first articles, one of the first investigations comparing manic patients with depressive patients, with euthymic patients and with healthy controls. And we realized that in both all bipolar patients, they perform worse, even the ones with in euthymia, than the healthy controls. Which are the main domains affected? Are attention, processing speed, memory, and executive functions. I'm going to talk about this a bit later. But this is according to different studies, different research, they found these are the main domains affected. Another question would be, when starts this impairment? So is this starts already in the beginning when we start, when we have the diagnosis, we have already these cognitive dysfunctions, or cognitive dysfunctions, they appear a bit later on. So there are different studies on this, but what we can say is that many studies, they point out that after first episode already we can find the first cognitive dysfunctions, and as well sometimes premorbid. For example, in relatives, first degree relatives, healthy, that they don't have the bipolar disorder diagnosed, they have as well some cognitive dysfunction. Would be interesting to talk. We don't have so much time today about this, but to talk about what is more, it's a neuroprogressive aspects or more neurodegenerative. This is something, it's a big discussion in the research family. And then we were talking before between subtypes of bipolar, bipolar 1, bipolar 2. So in both subtypes, we found cognitive dysfunctions, but maybe they are more pronounced according to the studies in bipolar 1. Then people with a higher number of manic episodes as well, they have a tendency to present more cognitive dysfunctions. Manic episodes, they are known to have more neurotoxicity for the brain. So people with a manic polarity, this means that they have a tendency to present more manic episodes, and the depressive, they can have more cognitive dysfunctions than the ones who doesn't have this manic polarity. Is also increased in patients with history of psychotic symptoms. Psychotic symptoms, they can be as well very neurotoxic for the brain. And what we have to know is that, I mean, I'm going to talk about this later on, but just for the first picture to say that there are not so much available treatments that they can. So, for example, enhancing drugs, that there have been many drugs used in different trials to try if they can improve, if they can enhance cognition. So far, there is no single drug so far approved specifically that can enhance cognitive dysfunctions. Then we are going to talk about some interventions that have been proved to help. We are going to talk about that it's related to functional dysfunction. And this is why it's so important and should be considered a critical clinical and therapeutic target, the cognition. Which are the main or the most common cognitive complaints of our patients when they come to the clinic and they see us and they say, okay, so what happened to them? So they say that they can concentrate in a book, that they have difficulties in watching a movie and follow up the plot of this movie and to see and to remember who is who in the movie. They have as well the feeling that they lose the track of time. So sometimes they have difficulties to arrive on time to the appointments. They get distracted very easily. So when they try to do something that they require some concentration, they can't hold on not long time. Sometimes they don't remember what someone has just told me, and this of course have some impact on and difficulties on following and participating in a conversation, what happens. And then sometimes people decide to avoid social contact because they don't feel secure, they don't feel confident to be there, because they are scared of losing something, or that they cannot really follow the conversation, or sometimes to bring some topics on the conversation. This is another complaint. So they feel mentally slower. They forgot the appointment with a doctor or with the friends or with whatever. They have difficulties in organizing their day. We are going to talk about this because this is related to executive functions. They don't remember where I parked my car, for example. This can happen to everybody as well of us. But it's true that this accumulated and different domains, attention, memory, executive function, this of course has an impact, important impact on the daily life of our patients. Which are the cognitive domains? And I'm going to explain shortly what this means to have problems and what does attention, the meaning of attention. So the attention is the ability to focus and concentrate. There are different types of attention. We can have a sustained attention. This means that we can focus on a task for more than 20 minutes. We have as well the dual, I don't know in English, divided attention, I think is it called, that we can be pay attention in two things at the same time. So there are selective attentions that we can concentrate even though there is a radio, there is a TV here next to me, so I can follow my talk. So we use a metaphor, like a symbolism for our patients is a spotlight. So there's a spotlight that allows us to illuminate what is important, what remains dark, we can't remember afterwards. So we learn them to have control of this spotlight. When we have problems in attention, so we are easily distracted, we are unable to stay focused, we lose the track of the conversation or of a movie, as we said, as we saw these complaints. The memory is the ability to learn new information, encode it, store it in our brain, and retrieve it when it's needed. We use a metaphor, a symbolism for our patients, which is a library. So we are the persons in charge for this library. We receive many information every day, many inputs. So we are the person who has to in charge to decide if what we throw it away, and especially how we classify the information we receive. This is how we work with our patients to learn them how to classify, because we better classify, we will be able to retrieve this information. So when we have problems in memory, we have difficulties in learning new things, or forget the things that we have done or said. So this causes a lot of daily impairment as well. Executive functions, the symbol, the metaphor for this is the director of orchestra. So this of the brain, this is the prefrontal cortex. We were talking about this before, and these executive functions are responsible for planning, for making a decision, for reasoning, for flexibility. So there is something that we were not thinking, so we have a plan, but then something happened. We were planning to go out in a restaurant at a terrace, but it's raining, so we have to be able to have this flexibility and to change and to take a plan B. So inhibition of inappropriate responses, so this part of impulsivity as well, that we can be adequate in a social context. So these executive functions help us to adapt our behavior to the environment, which is very important, of course, for work scenarios, for social scenarios, etc. And another one, which is more and more, because this social cognition was more related, or they were finding more problems in schizophrenia. But recently as well, there are many studies that we found that social cognition is as well impaired in patients, bipolar patients. And social cognition has related to emotion recognition, which is allow us to recognize the emotions of the others, how the emotions interpret facial expressions, tone of voice, body language of the other people. Theory of mind, that this is a mistake, of mind. This is understanding that people have thoughts, beliefs, and intentions that they are different from our intentions, and how to interpret what the message from the others. This is very important as well in social settings, just to be successful in these aspects. Attributional style, this is how individuals explain the causes of events. For example, someone interprets a neutral situation as hostile or accidental. So This is very important to work on this attributional style, because sometimes there is a lot of place for misunderstandings if there are problems on these areas. The social perception is like grasping social roles, norms, contextual cues to navigate interactions appropriately. And finally, empathy belongs as well to social cognition. When we have problems, is the ability to share and understand other person's feelings. And this is very important when, of course, we are in a relationship. So sometimes there are studies where we found that patients with bipolar disorder have problems in this area as well. So moving a little bit to this study, this is the first study. This was published as an American researcher, Catherine Bardick. She published a lot and she studies a lot about cognition and bipolar patients. And this was one of the first study. Afterwards was replicated. So this means that other people, they got the same idea with another sample size, with other patients, and the results were the same. In our group, for example, we replicated as well this study. The idea is just to make groups. So this was a group of, I think, was like 130 or 140 patients with bipolar disorder, and they were clustering. This was a cluster analysis, so they tried to group them according to the cognitive performance. And what they found with this analysis is that there is a group of bipolar patients, which was an intact group with performance comparable with healthy controls on all domains. Is this group that I was, is here assigned with this red arrow, because this is where the zero is in this line here. This is where the healthy controls are. So we can see that this subgroup is what we were talking before. We were talking that 40-60% they have cognitive complaints, but the other rest they don't have. So this would be this intact group. Then we have a second group with a selective impairment with moderate deficits. So they have some deficits in some domains, but still the functioning is okay. And then we have a third group, which has a global impairment with severe deficits across all cognitive domains. And this group is very similar to the schizophrenic group. As we can see, they were comparing with the fourth group, the schizophrenia. This is with the black, a little bit more, a darker line. And these two groups, you see that they are quite similar regarding performance. So this is interesting for us regarding interventions and regarding assessment and regarding just the importance of adapting to the different subgroups, because it's not the same one person with almost no cognitive dysfunctions and the other group that is similar to a schizophrenia group. So this is very interesting, just to personalize, to tailor the interventions. So this paper was this article, this research was very important in this time. And as I mentioned before, so as we mentioned, there is a group with similar performance, a subgroup, similar performance with schizophrenia. But this is an old publication from our team, but the question is that, as I said, cognitive domains affected seem to be qualitatively similar in both disorders, but quantitatively deficits seem to be more severe in schizophrenia. But of course, when this article was published, we didn't know the results of these different clusterings of bipolar patients, where as a subgroup as well can perform very similar to schizophrenia. Another question for today. So what are the factors? We are talking that some people, they will develop some cognitive dysfunctions and other people not. So what are the factors that implies more cognitive dysfunction? So first of all, we have clinical factors, as I said before. Manic episodes are more neurotoxic, higher chronicity, so an early onset of the illness, so more duration of the illness gets as well, has more impact in cognition. The number of hospitalization as well as a sign of severity as well. So more hospitalizations, more cognitive dysfunctions. Suppressed depressive symptoms. This is something that we observe a lot in the clinical practice. Some people that they are not depressed, but they are still not in a normal functioning or premorbid functioning, so the functioning that they had before the illness onset. So it's important, these clinical factors. Another factor is unhealthy lifestyle. Of course, sleep disturbances. Now we are very focused on the study of sleep. How important is the sleep, the quality of sleep, not only the time, the hours that we sleep, but the quality of sleep is very important. Um, of course, because depending on the sleep pattern, can impair neuroplasticity, either can increase inflammation, worsen metabolic dysfunctions, etc. Substance use disorder as well, so alcohol or drug misuse, this is as well not positive or has a negative impact in cognition. And then a poor diet as well, for example, a sedentary life, so without exercise. Now there are a lot of studies as well that exercise improves as well in an indirect way cognition through this enhancing BDNF, which is a protein which is enhancing the connection between the neurons. Hormonal factors and stress. This is related as well to dysfunctions in the HPA axis, hypothalamic pituitary adrenal axis, so related to cortisol levels. So these cortisol levels has neurotoxic effects on our hippocampus, as I said before, is this little area which is inside the limbic system, and that has to do or is responsible of encoding new information and of the memory basically. So this is important as well to check all the how the hormones are. Then pharmacological treatment. This is as well a big issue in our research, because sometimes there is this myth that patients, when we do some groups with patients, they say, yeah, so I stop with the medication because the medication is the cause of my cognitive dysfunction. And this is something that there are many studies on this, and this is not clear. So there are some drugs, particularly drugs that they can cause, of course, more as slowness, some retardation, psychomotor retardation, etc. But it's true that in other studies they point out that the medication prevents us of new episodes, and we know that every episode is an increasing as well of impact on cognitive dysfunction. So pharmacological treatment can be some protective as well, but we have to see and to check as well, not polypharmacy, for example, on some aspects of pharmacological treatment. Can be so individualized pharmacotherapy would be always always interesting. Some demographic variables, of course, so age, older age, more cognitive dysfunctions, educational level, this of course higher previous educational level, this is protecting as well of cognitive dysfunctions. We are going to talk about now about cognitive reserve, and you will see how important is cognitive reserve now. And sex as well, there are some differences according sex, especially some domains are more affected in women, others more affected in men. There are a lot of studies in sex differences and cognition right now. And another thing very interesting, which is quite new in the sense of research, is the childhood trauma. So early life adversity, including abuse, including neglect. We are not talking only about PTSD, but of course, some adversity has been consistently associated with greater cognitive deficits in adulthood among bipolar disorder patients. Because these experiences, this adverse experience, can generate brain alterations because of the stress reactivity, neural connectivity. So some epigenetic changes can influence this early experience. And finally, cognitive reserve. This is one of the cognitive reserve is an idea which comes from the dementia. So I'm going to talk now 2 slides about this. So Jakob Stern, you can see here in the picture, he is one of the most of the fathers a little bit of the study of cognitive reserve, and he describes it the cognitive reserve as the brain's capacity to use alternative neural pathways or different strategies to cope with brain damage. And this was observed for the first time in dementia. So people that they had, for example, um, the very well-known study of nuns. There were some nuns. This was, I think, was in Minnesota where the study was developed. So they were studying a monastery with different nuns. They were like they were between 80 and 100 years old, and the informed consent for the study was once they were passed away, they were giving their brains to the study. And when they observed, this is a very interesting study because the nuns, the sample was very similar because they were all living in the same, they had all the same lifetime habits, not lifetime, but when they were living together, all the same lifestyle in this moment. They were all very dedicated to writing, to meditation, so no drugs. They were all women, so this was some sample quite homogeneous in this sense. And they were, when they passed away, they observed that some of the nuns, they presented signs of Alzheimer, for example, but they were not diagnosed. So clinically was not observed. So this was very interesting in this moment to see that maybe in these people with more cognitive reserve, which is related to is an abstract concept, but we use some proxies, which is like premorbid IQ, that this is not modifiable. So we are born with a certain IQ, but then educational and occupational level, this we can modulate. So we can study more or less. We can work in certain levels, and then intellectual and leisure activities, all related to reading, to play an instrument, to learn a new language, etc. All these things, they are enhancing our cognitive reserve, which can be protective after when some brain disease comes, so can create like a little bit of a compensation. So we have a lot of we are now in our lab. We are just studying this cognitive reserve in high-risk populations. So on offsprings of patients with bipolar disorder or schizophrenia. We are just observing that we prepare like a program for them to stimulate or to enhance cognitive reserve. This can be preventive of starting the disease, or just to delay a little bit the onset. Okay, this is. And then I present Jennifer Barnett, that she's adapted this aspect of cognitive reserve more into psychiatry. So she studied this a lot in psychosis, and this proposed like a protective factor, cognitive reserve, with a later onset of psychosis. So people with a higher cognitive reserve, they have a better prognosis, a greater adherence, and fewer psychotic symptoms. As well can predict functional, so they have a better functioning and neuropsychological performance. And on the opposite, for example, low level of cognitive reserve is associated with more negative symptoms. So one of the conclusions that we think right now after all these studies is that maybe cognitive reserve may be useful in explaining these individual differences at neuropsychological and functional levels. The heterogeneity that I was talking before, these different subgroups of patients, maybe it is mediated, one of the factor that differentiates them, maybe it's cognitive reserve. This is just an hypothesis. And to share with this concept of mental capital, so that there are things which are positive influences in our mental capital, like for example good parenting skills, that we have an early home and a good environment, that we have supportive teaching in the school, that we don't receive bullying, for example, that we are very social engaged. All of this through lifetime, this is increasing our capacity to our resilience, capacity to adapt, capacity to cope with the different situations, with a better cognitive development. And some of them, environment, when we don't have an environment enriched, for example, that we have some early stress exposure, as I was talking before, like childhood trauma, etc., some afterwards, some drug and alcohol use, abuse, social exclusion, stress, and different aspects of stress. So this is a thing that we are just decreasing our mental capital. So we think that treating this cognitive impairment through different skills can help to improve functional outcomes and well-being of our patients. And I'm going to talk about this a bit later on. And another question for today is, how is the trajectories of this impairment? So one of the questions that we receive more from the patients is it going to finish with the dementia? So I'm going to, if I have all these cognitive dysfunctions, how is going to end up? So there are studies that they observe the trajectory a little bit of these cognitive dysfunctions. So here this is interesting study. We're comparing healthy controls and bipolar patients and schizophrenic. So when we see it, normally the premorbid stage, so this means that before starting the illness, there are a lot of studies, of cohort studies, that they follow up children until they develop one of the of mental illnesses. They are long cohorts follow up. They found out that schizophrenic kids, they all present some difficulties in some cognitive tests already in language and some aspects. And normally what we found out as well, interestingly, is that a percentage of patients with bipolar disorder, they present like an excellent academic performance sometimes. So they perform better sometimes than the healthy controls. And this is interesting as well, because once the first episode, we see already, you can see here in this arrow, so that there is already a little decline. And then with bipolar disorder, what happens is, according to episodes, maybe there is an increasing of decline if every episode happens. And for the schizophrenia, so they start from a point a little bit lower than the bipolar patients, but then so the differences, so there is much more impairment, but that remain a little bit stable. And with bipolar disorders, according a little bit to different number of episodes. This is what I'm saying is interesting regarding then our clinical practice, because patients, sometimes we found out patients that they used to have a very, very good performance before. And they have difficulties to accept now that they have difficulties of reading, difficulties of following a movie, when they are talking about that a lot of people, not everybody, but a lot of people, a percentage of patients with bipolar disorder, they've been in the university, they had maybe good jobs, and then now they realize that they have difficulties that they were not used to have. So to cope with it, this is as well our job to help them as well to try to improve this, of course, but then as well kind of acceptation. Regarding dementia, this is still not very clear. There are some studies that they have that maybe patients with this diagnosis, they are more prone to develop dementia, but still there are not much data to conclude something clear. Our fifth question for today is, there is an association of cognitive performance and functional outcome. And this is the important thing of that cognitive symptoms is affecting social and work difficulties, create some isolation, and then this can create another relapse, and we go into this round. So there are a lot of everyday activities, interpersonal relationship, employment, etc., that are limited by these cognitive dysfunctions. So, independent on that, they have a clinical remission, they have difficulties to go back to work or to go back to the early life. So when we talk about functioning, there are different definitions, but we talk about the capacity to work and study, to living independently, to maintain interpersonal or romantic relationships, and capacity to maintain leisure activities. And this is as well a very relevant study published many years ago. This was done in the Macklin Institute here in America. And then they were following 200 persons with a first psychotic episode for 2 years. And they were observing that after 6 months, these people, almost 80% of the patients, they had no more, they had a clinical remission. This means that the symptoms were gone, the clinical symptoms, but only a 30% they recovered functionally. This means that they recovered, they get again the premorbid functioning again. But after 2 years, so almost all patients were recovered. We can see 98% clinically recovered, but still only 40% they could back to their premorbid functioning. So this is still something pending, something that we have to work on this, all this kind of functioning. And as we see, one of the variables associated with functional decline is these neuropsychological variables. Other, of course, other environmental variables, social and family support, clinical variables that we talked before as well, but neuropsychological variables as well, they have an impact. So how we can help, how we can treat all this function. So first of all, important to achieve clinical remission. So by treating subclinical depressive symptoms as well, treating comorbidities, this means other diagnoses that they come together with the bipolar disorder, to watch as well what happens with pharmacotherapy, to be as much as ecological possible, healthy habits, again, physical exercise, diet, sleep, and to implement some cognitive and functional rehabilitation. And this is my last part of my talk. So talking a little bit about cognitive remediation, and because this is one of the most accepted, and then we have many literature that this is something which improves cognitive performance and daily functioning through structured exercise and compensatory strategies. So we have the cognitive remediation can be some restorative, so aim at improving functioning of impaired cognitive skills, or as well focusing more compensatory, focusing on teaching strategies to manage the deficits. So here I present some studies, some systematic reviews or meta-analysis, which they show that there is effects on attention, verbal memory and learning, working memory, executive function, that this is improving. Sometimes as well, we can see some improving in depression and depressive symptoms. It's important for further studies to the durability. The problem sometimes is because there are not so much follow-up studies, and sometimes what happens is that is improving and it's helping and it's effective at the beginning, but then doesn't last so long. And then the other key point, this is very important for us as well, is just if this can be applied in real life. So this is just if I improve some cognitive tests, for example, if I do better some cognitive, is this helping? This will help me in my daily life when I have to work, I have to go to study, I have to organize my daily life. And this is a recent systematic review meta-analysis by Samame, which is a group in Argentina. They work a lot in cognition as well, that they found significant effect size in improvements in working memory, planning, and verbal learning with cognitive remediation in bipolar disorder, but they failed to find improvements in functioning either post-intervention or even either not in follow-up. Other studies, they found that some positive effects on cognitive performance, but limited effects on functional outcomes. And this is maybe the problem. And then this is why we decided in our group to implement this new intervention, which is focused on improving psychosocial functioning through cognitive techniques applicable in daily life. So it's including not only cognitive improvement, but also psychosocial adaptation. We published a manual that paradoxically is only in English written, so we still don't have the Spanish version or in other languages. And so I'm going to shortly present, so this is based on this kind of modeling, scaffolding, role-less learning, role-playings, positive reinforcements, metacognition. And I'm going to check the time, and I'm going to shortly present this study. It was a multi-center study we performed this in 10 centers in Spain. And basically, the program is lasts 21 sessions. So this is like 6 months, weekly, 1 hour, 1 hour and a half. And there is like divided in 4 modules. We have a module that we talk about psychoeducation and neurocognition. So we talk about why we have cognitive deficits in bipolar patients, why, which are the positive factors or which are the negative factors that influence negatively to the cognition. Then we have another module that it's more related to improve attention, memory, and executive functions with different techniques, internal strategies, external strategies. We read together through the different sessions a book, every day a chapter, and then we do little summaries, little abstracts of this book just to put it in common. And this helps as well to take again this habit of reading. We have another module of stress management. As we know, the stress creates as well, cognitive dysfunctions, and then we work on this as well. And finally, all the social skills, improving autonomy and functioning. So this is more related to how to improve active listening, all this kind of social cognition that we had discussed before. This is very practical. People have there's a part with 20 minutes of theory, but then we have a lot of practical in the group, and then after that they have to do some homeworks as well. This a little bit, I just don't go into detail. If somebody's interested, they can of course send these sessions. And basically, to finish now, is that the idea that we propose as well is the different aspects. So depending or according to the phase or to the moment of the illness, to apply a different intervention. For example, just when we start, so this will be psychoeducation, maybe to avoid some multiple episodes. So at the beginning, when people start with the illness, then for example, functional remediation, we have the idea to implement it is more when there is a little bit of more episodes that people have some functional dysfunctions, then maybe it's the time to intervene and to start with functional remediation. And for example, enhancing cognitive reserve, as I mentioned, really in the prodromic phase or really in genetic vulnerability, so with high risk population, for example. So this will be interesting to adapt or to implement the different interventions according to the phase or according to the stage of the illness. So to go to the end, this will be like a protection plan, and we designed for the patients like psychoeducation. So it will be interesting to reduce the number of episodes, some stability with sleep patterns, no consumption of toxic substances, staying physically and cognitively active, physical exercise that has been shown that has a lot of impact, positive impact on functioning and cognition as well, and then all this cognitive stimulation exercise. So thank you very much for your attention. Here's my mail, and now I think we still have time for questions, comments. So I'm very happy to answer.
Amazing. Okay, well, thank you so much again for presenting. We really appreciate you taking the time out of your night. I know it's nighttime there, so we really appreciate it. Yeah, I'll open it up for questions if anybody has any questions for Dr. Torrent. Now is the time. And we have about 10 to 15 minutes, so. All right. Do you have any additional psychoeducation resources that you recommend? Any apps, podcasts, or anything on your end that you think are helpful?
Yeah, the problem is that my resources are more in Spanish language, so maybe this I can't. But yeah, for example, in the ISPD web, for example, for International Society of Bipolar Disorder, I think they have some as well, some booklets that we can take it in a different languages as well.
Okay. Let's see. Are there any meds that are used specifically for cognitive impairment?
Mm-hmm. Okay, so when I mentioned that there were no pharmacological treatment approved for cognitive impairment, so they did different studies, for example, with drugs that they were used, donepezil, for example, galantamine, so that they used for dementia. So they would try to apply this for psychiatric disorders, but was some studies they showed some improvements, but not much. And the one, for example, the last one that there was used, and that this was the first trial where the primary outcome was cognition, because sometimes they use, for example, antidepressants, but the primary outcome is to improve depressive symptomatology, but not really cognition. And this was with vortioxetine. Vortioxetine was used for some trials, but they didn't show really differences enough just to, there's some improvements, but not enough to get the approval for a drug just to treat cognitions, because maybe it's like an indirect way. So maybe they are improving depressive symptoms and indirectly they improve cognition, but they were not showing enough power to 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 consider this drug for to treat cognitive impairment.
Hmm. Fine. Can you elaborate on precognitive drug therapy? What is it?
Well, this is a little bit what I was talking about now, yeah, about this.
Uh-huh.
I think it's related to drug
Yeah, I
enhancing.
guess.
I think it's related to enhancing.
Okay. What about older adults with bipolar? What happens cognitively? I
Yeah, this
guess
is
is
very
there a
interesting.
connection?
We are just very good question, because of course we have to take into account some differences of related to age. Of course, they have some physical comorbidities, etc. So what we did now is recently, this is now a project which is recently founded, and so we adapted this functional remediation program to seniors. And now, according to the ISBD criteria, so we consider an older, no, with 50 already, no, so from 50 years old already. So we include patients with between from 50 years old on. And then so the program is a little bit different because it's more intense. So it's like 32 sessions instead of 21, and we do twice per week instead of one. And then so the idea basically is we try to help them as well more ecologically in things, for example, that they need some support in daily life to organizing their tasks, regarding, for example, all this technology that sometimes they have a little bit problems as well to cope with it. So we do very practical sessions orientated to how to deal with their daily practice,
Mhm.
daily tasks. So, and but this is a very interesting point, because we have to, sometimes they take medications for other physical comorbidities. So this is, we are studying now this and this population.
Mhm. I'm going to scroll down a little bit. There's one that I thought was interesting. Do you see patients getting cognitive, or I guess their cognitive functioning better the longer that they're stable, maybe getting back to almost normal, or is it forever weakened?
I didn't get this question, sorry. If I
It's down at the bottom. Sorry, I'm scrolling a little bit. Do you see patients getting their cognitive function back the longer that they're stable, like getting back to normal, or is it forever weakened?
Yeah, okay. So if I see improvements, no, it is the question.
Hmm. Hmm.
Yes, I see
Essentially,
improvement.
yeah.
Yeah,
Does it go
yeah,
back
yeah.
to normal, or do they have, you know,
Mm-hmm. Yeah.
long-lasting effects?
Yeah, this is a good question. So we have again a little bit these differences. So there are people who can completely recover, as they were this subgroup, so they can get back to work, they can back to their life before. Um, and some people, they still have some difficulties, but through this intervention they can get some strategies that they can help them. So there are maybe difficulties, but they know how to cope with it, and they learn a lot of internal and external strategies like use of agendas, of apps, of many things that they help them in their daily lives, and some internal strategies as well. So how to all these self messages that they can tell them to themselves, etc. So I would say that is a little bit a mixture as we see in this heterogeneity. So some because sometimes there is multifactorial as well. So apart from the group, there is people who have received more support from the families, or they have, for example, more flexible work, and the boss can understand and they can share this to the boss. Others they can't tell to the boss that they have these difficulties. So there are other factors that they play a role as well sometimes mm, to complete recover.
Hmm. Okay. Up a little higher, Lori asked, has any work been done with using music or building foreign languages to build cognition recovery? I guess,
Mm-hmm.
has either of those
Uh,
been used?
okay, so with music, you say directly with
Music or building foreign languages. So I think using, either of those to build your cognition
okay,
recovery.
okay. So directly studies, I don't know directly studies that they treat the people like this. I mean, to tell them just to learn new languages. What we do as well is to stimulate people just to go and do some external activities like learning a new language, or like so because we have like to assess cognitive reserve, there is like a scale, and then in this scale we take into account all these physical activities people do, and this is like a cumulative. So what they did during the childhood that they do actually, and then when they did last year, so they did during the youth, for example, depending on the age of the person, of course, and they did last year. So as many activities they can do, so this is better. I don't know any exactly study which they are just trying to, if they with this particular learning, for example, languages. But it's true that we
Hmm.
know that people who learn more languages, they have more cognitive reserve. This is true as well. Mhm.
Hmm. Okay. Do you know what percentage of patients with bipolar develop dementia in the long term offhand?
Yeah, this is a good question. I don't know exactly now. It's not a big percentage, but I
Hmm.
don't want to say a number because I'm not sure exactly now, because there are now recent studies that they are on this, because before, not so far, we were saying that no, that this is not, that they are not more exposed. But it's true that now we have to change our rationale. It's true that there is like a bit, sometimes it's a higher risk,
Hmm.
but exactly percentage I'm not sure now, because they are depending on the study. Not so, it's a higher risk, a little higher risk, not so much, but we have to take this into account as well.
Hmm. Okay. On Facebook, on our chat, somebody asked, are there any at-home strategies you recommend to help improve cognition?
Mm-hmm, yeah. Okay, yeah, there are many that we share with them in the group, but basically there are many of related to organization at home, for example, so that everything has to have a place. This helping a lot. And then, for example, to have some use, because sometimes it's not the only the strategy, it's how we use the strategy. Because, for example, some people use post-its, for example, to remember the things. The problem is they use so many
Hmm.
post-its that then we don't know, or they fall down. So the important is that to optimize the techniques we use. So all related to organization. This is depending of if he lives by himself, if he lives with a family, he has to take care of some family, for example. So then it's important as well to have a calendar where everybody can write down what they have to do. So calendaries, agendas. Sometimes people likes, they prefer to do it by writing. Others, some apps or some technological strategies that are okay as well. So all related to helping to the organization, to help to remember the appointments, for example, to help to um, and by cooking as well, the list of things that they have to buy as well, very clear, sometimes helping to categorize, for example, to make a list. Okay, so first, what I have to relate to vegetables, or meat, or, so just to make shopping lists by categories as well. This is helping a lot. So this is like internal strategies we share with them, how to categorize, how to, so to create that this information makes sense for them. And this is the sense of the strategies, basically.
Okay, great. All right, I think we have time for a couple more. I saw this one on Zoom. Does IPSRT, or interpersonal and social rhythm therapy, help with cognitive impairment and bipolar specifically?
This is a good question, because they talk. I mean, the problem is that we don't know exactly, because this was not the primary outcome. Yeah, the primary outcome for these studies were always to prevent relapses, and this is helping, of course, for prevent relapses, because they work a lot on these sleep patterns, on these social aspects, on all this I mentioned before that was important for illness management. But cognition is not primary outcome in the study, so we can't say if it's like this. Probably, yeah, indirectly can help as well, but the studies are not designed for cognition and to find improving in cognition, so and state is like this.
Okay. I think the last question, I did see some people asking for the Spanish resources, if you do have anything just off the top of your head that you think is helpful
Okay,
for
so
Spanish speakers.
for Spanish speak. So resources for cognition or for
I
psychoeducation?
think cognition, this person said, any specific reading resources for guidance on enhancing cognitive reserve. I'm a Spanish speaker, so Spanish resources would be very helpful.
Okay, so I have a list that I don't. Maybe I can share with you. You can share. Oh, how is it
Yeah,
working? I can
yeah,
share
you
with you.
can share it. Of course, we can post it.
Because I have to
Some,
find out
yeah,
now, so then not
okay,
losing time. But I will share with you, and then you can share.
okay, great. Yeah, we can post that. Maybe we can put it on our website with this webinar. We can attach it as
Okay,
well. I think that'd
okay,
be great.
okay.
Yeah,
I will send it to you. I will write down.
perfect. Okay, well, I think we are running low on time, so I'm going to go ahead and stop there. Thank you so much again for joining us. Again, we really appreciate you taking the
Right.
time and talking and sharing. Thank you everybody for joining us. And again, this recorded version will be available on our website shortly. So if anybody missed anything, or if you joined late, you can go ahead and watch from the beginning there. And then is there anywhere that they can find you, or anything you want to shout out before we go?
Where they can find in my email, you mean, or?
No, just if you have anything you want to shout out.
Well, I mean, thank you, because people were very active, no, and a lot of questions, and so happy to share, and hopefully, so this was helpful.
Yeah, no, I think so. We had definitely a lot of interest in the topic. I think it's something a lot of people deal with. So it's very helpful. But yeah, thank you, everybody. Everyone has a
Okay,
good day.
thank you.